Welcome back. Today we'll be discussing Chapter 30, which covers multi-system trauma. I think this chapter should be called Trauma Overview, and I also think this should be at the start of Section 5, because this kind of covers multi-system massive trauma patients and just in general how our trauma systems work. That being said, this will be a relatively quick chapter, so that's the good news. The bad news is, as far as the presentation goes, it's a lot of definitions, so it's going to be a lot of me kind of reading from the slides as opposed to what you're normally used to with me. So let's bear down and get through this, and it should be a nice, quick, and sweet chapter. So the three topics covered are trauma overview, multi-system trauma, and then overall management of the multi-system trauma patient. So going into trauma overview. One of the biggest things that us as EMS providers need to do is select the appropriate hospital for our patients. There's three different major levels of trauma centers, and there's different capabilities that each one can do. Level 1 is the highest level trauma center, so that will take any sort of trauma patient, period. Any trauma patient can go to a level 1 trauma center. So a characteristic of level 1 trauma centers is that they have 24-hour in-house trauma surgeons. So that means that they always have a trauma surgeon right there ready to roll with your trauma patient. They provide comprehensive care to all types of trauma patients, so they can really handle anything. In the Syracuse area, the level 1 trauma center is upstate. Going into level 2 trauma centers. Level 2 trauma centers are usually seen in smaller cities. So, for example, Utica has a level 2 trauma center with St. Elizabeth's Hospital. There's also a level 2 trauma center, I believe, up north. I'm not exactly positive on which hospital it is, so don't quote me on that. But they're kind of smaller regional hospitals, can be level 2 trauma centers. So their goal is to initiate care on trauma patients, and then depending on how bad the trauma patient is, they'll stabilize, then transfer them to a level 1 trauma center. One characteristic of them is they have 24-hour availability of trauma surgeons, which means that they can call one in, but they might not necessarily have one in-house 24/7. So that's one of the big key differences between level 1 and level 2 trauma centers is level 1, they are always in-house. Level 2, they are on call. Then your level 3 trauma centers, these are usually more rural areas, and their goal is to assess the patient, provide a little bit of resuscitation, a little bit of stabilization, and then transfer them out to a higher level trauma center. So level 3 trauma centers, a lot of hospitals actually meet the qualifications for level 3 trauma centers. And again, they mainly just say, this is above our scope, let's stabilize and get them out of here. So, like I said, knowing the different trauma center levels and what they can do is critical for us because we do need to select the appropriate hospital to bring our patient to. Otherwise, it can significantly delay their care and them getting to a proper physician. So the highest level trauma center is ideal, but you have to look at the patient. With upstate and Syracuse being a trauma center, if you're working the city ambulance in Syracuse, do you take every stub toe to the level 1 trauma center? Absolutely not. So look at your patient's injuries, and there are guidelines to what injuries need to go to a trauma center. And then if you do have a patient that meets the criteria for a trauma center, you also have to look at, is it practical for you to go to that trauma center yourself, or should you go to a closest hospital first? So that's some things you need to take into account is your distance to the trauma center, how patent their airway is, and where your closest ALS is. If you are 50 miles away from upstate, but you're 5 miles away from Oswego Hospital, and you don't have any ALS close, it is appropriate to bring the patient to Oswego, have them stabilize, and then have them transfer the patient out. You also have the option to use air medical, especially if you are in a rural area. Aeromedical is a great option to get someone to a level 1 trauma center very expeditiously. A lot of hospitals with trauma patients will transfer them out via aeromedical. So keep that in mind. And we do have the 2 rules of thumb is we have the golden hour and the platinum 10 minutes. So the golden hour is what we refer to from the time that the incident happened to time that the patient is in front of a trauma surgeon. That should be less than an hour. So take that into consideration when you're considering aeromedical and when you're considering transport destination is, can we get this patient to a trauma surgeon within the hour of the incident? That's one of the biggest reasons to use aeromedical is if you can't do it by ground, you can then fly them. And then you have the platinum 10 minutes. This applies very much so to ground transport. So the platinum 10 minutes is the amount of time that you want to spend on scene. You do not want to go over 10 minutes on scene with a trauma patient once you've made patient contact. I say make patient contact because if a patient is entangled inside of a car and they need to be extricated and it takes 30 minutes to get them out of the car, your 10-minute timer doesn't start until you can actually access your patient and get them to your ambulance. So platinum 10 minutes and golden hour, those are 2 huge things to keep in mind. So right here is the national guideline for the field triage of injured patients. This was handed to you guys on day 1 of our trauma section. If you don't have it, it's very easily found on Google. If you just type in national guideline for field triage of injured patients, this should pop right up. So the red criteria, all that stuff there, are criteria where a patient should be transported to a level 1 trauma center if feasible. So you can see all that in the fine print of penetrating injuries to head, neck, torso, and proximal extremities, any skull deformity, any suspected skull fracture, suspected spinal injury with new motor or sensory loss, chest wall instability, deformity, or suspected flail chest, a suspected pelvic fracture, a suspected fracture of 2 or more proximal long bones, crushed, degloved, mangled, or pulseless extremities, amputation proximal to the wrist or ankle, and active bleeding requiring a tourniquet or wound packing with continuous pressure. So that's all injuries that should go to a level 1 trauma center if possible. And then for findings, so we have kind of our mechanism of injury. As far as findings go on your assessment, if their GCS is less than 6, if their respiratory rate is less than 10 or greater than 29, if their respiratory distress requires respiratory support, if their room air pulse oximetry is less than 90%, all those patients should go to a level 1 trauma center. And of course, this is all things that are because of trauma causes. And then you can see there's different vital sign findings for different ages. And then in the yellow section, these are all patients that should go to a level 1 trauma center preferably, but a level 2 trauma center could possibly take care of them. So I'm not going to read through the entire list of this entire sheet because you can pause and look at it, but this is something that you do need to keep in mind and really memorize the key points of it, because it will be your responsibility to see this in the field and determine, yes, this patient needs to go to a level 1 trauma center, or no, they do not. That is on you to know what hospital this patient should be transported to, and we need to utilize our trauma centers appropriately. So like I said, if you have a simple, say, a leg fracture, and it's just a 1 tib-fib fracture, that doesn't require a level 1 trauma center. So we can keep them free for something that does require a level 1 trauma center, such as a penetrating trauma to the chest. So definitely look at this a lot more than me just going through it for a couple minutes on this, and actually learn all the content on this form, because you are required to be able to know this. Another term that we've brought up before but need to bring up again is distracting injuries. Now, there are 2 different types of distracting injuries. There's distracting injuries that distract you, and there's distracting injuries that distract the patient. So we'll take a femur sticking out of the leg, for example. Incredibly painful for the patient, and the patient's going to be staring at their broken bone. So the patient, because they are in a ton of pain there and they're have their attention diverted to the gross injury, they're not going to think about the mild neck pain that they might have. And then we might miss a spinal cord injury because the patient's not reporting that to us. And if you don't specifically ask about it, they might not ever think about it because they are distracted by the injury that they see. Then you also have the distracting injury to the provider. If you have that femur sticking out of your leg, it's gonna take your attention. We're human. We will be looking at that, and it's going to distract us. We need to be able to not get tunnel vision on that one broken femur and focus on our entire assessment before we actually get into the isolated treatment of non-life threatening injuries. So be very cautious of distracting injuries and know that they can happen to both you and the patient. All right, moving on into some multi-system trauma. So we have a couple definitions here. So there's a multiple trauma patient. That's where a patient has more than one serious injury. Versus a multi-system trauma patient. That's where you have more than one or more injuries serious enough to affect more than one body system. So you might have an injury that's affecting the musculoskeletal system and an injury that's affecting the respiratory system. You might have an injury that's affecting the neurologic system. So that's a multi-system trauma patient versus multiple trauma could be multiple injuries to the musculoskeletal system. So you might have 20 lacerations to the patient, but that's all one system. So that's a multiple trauma patient versus a multi-system trauma patient. Generally speaking, a multi-system trauma patient is going to be worse off. One of the most important decisions that you can make is this patient a priority or not? It's the sick or not sick decision. We talk about that on medical. Same idea with trauma. Is this patient sick or not sick? Is this patient going to die soon or not die soon? Are they a priority or not? If they are a priority, that means you need to limit your scene time. You are not going to do much to save their life minus supporting their ABCs. They need a trauma surgeon. ALS isn't going to do much to save their life. Even the hospital emergency department is not going to do much to save their life. They need a trauma surgeon to go in and fix whatever's happening. So don't wait around on scene to do everything perfectly and to get your first set of vitals while you're sitting still and blah, blah, blah. And get these patients moving. And then your next decision is which hospital and transport method is best for your patient. So are they going to a level 1 trauma center? Are they going by ground? Are they going by air? These are all your decisions as the in-charge EMT, and these can drastically affect patient care. This can change if the patient lives or dies based off of you identifying them as a priority and getting them to the hospital faster. Keep in mind that older adults do not effectively compensate for shock, and children also do not, they compensate very well for shock, which means we don't see the signs of shock as easily. So they go into decompensation very quickly because we don't see it coming. Kids also might benefit from going to a pediatric center. Fortunately, in this area, the trauma center happens to be the pediatric center. That's the same over in Rochester. Their trauma center is their pediatric center as well. So keep that in mind that you might need to balance pediatric versus trauma center, which one the patient might benefit more from. So training is key for traumas. You do not want to be caught doing something brand new when you have a patient that is in need of immediate care. So this is why we spend so much time emphasizing your skills, especially near the end of class, and being able to do your full proper trauma assessments. Also, on the way to the call, you should know what your role will be. If I'm on the way to a call with a partner that I don't know about, we discuss who's going to do what when we get to the scene. If I'm working with one of my normal partners, they know, for example, on a critical call, they have the airway management while I'm doing other things as the paramedic. So they know they're going straight to the airway, they're taking care of that for me. That is a critical point of letting a call run smoothly is not being fumbling around when you get on scene of, oh, who's going to do what. You should have that set before you ever arrive on scene. That being said, you might need to adapt these things if needed. If the patient doesn't require airway management, my EMT is going to be doing something else. So be flexible, but have a vision going in. Also, keep in mind scene safety. Don't get that tunnel vision again of just treating the patient. You have to have full recognition of what's going on in the scene. If you're on the scene of an auto crash, for example, there might be passing traffic. You can't be so focused on patient care that you start walking to the ambulance and you don't realize that there's a car coming at you when you go to walk to the ambulance. Also, with any sort of penetrating trauma, if it's an assault, the assailant still may be on scene. So make sure that the scene is secure before you arrive on scene. That's something that I personally was very bad at when I worked in the city of Syracuse, was going straight into shooting patients without police. So that's something that you really should keep in mind, that sometimes assailants might still be on scene, especially if you're only a block or two away when the assault actually happened. So make sure that you assure your scene safety. As far as treatment of these patients, you want to, again, once you get the scene safety, you want to do your primary assessment, make sure they have a good airway, perform your urgent or emergency moves. If you remember that from lifting and moving, if you need to move the patient, you move the patient. So we discussed that at length with lifting and moving for urgent or emergency moves. Then transport. Notice we aren't doing our secondary, we aren't doing our vitals, we are transporting, then doing the rest on the way to the hospital. Time is of the essence there. I don't really care what their blood pressure is if they're conscious, if they are a level 1 trauma patient. I care about getting them to the hospital. So yes, we need a blood pressure, but I don't want it on scene and burning time. I want it on the way to the hospital. And then it is also very, very, very important that you give a report to the trauma team before you get to the hospital and then after you get to the hospital. Before you get to the hospital so that they can assemble the trauma team and be ready for you, so that you, when you arrive, you just pull your patient into the trauma bay and they can start their treatment and assessment immediately. And then make sure that you give a full report to everyone there, which is a very hectic scene. Most hospitals are good about quieting people down, but you need to speak loudly and clearly and have an idea in your head of what you want to say before you actually have to give the report. That way you aren't stumbling over it, because they're waiting for that report to be done to start their assessment and treatment of the patient. So utilize that time wisely and efficiently so that they can get to their part of patient care. If your patient does have critical injuries, follow your priorities determined by your assessments. Do your ABCs. If you have a threat to airway, then you stop and you treat that threat at the airway. Don't delay transport by doing other treatments on scene that might waste time. If you have a threat to your ABCs and the patient has a broken leg, don't splint that leg, get them on the stretcher and get them to the hospital. Focus on treating your ABC threat. Once that's secured, then you can think about secondary injuries. But if you can have a perfectly splinted leg, but if you don't take care of your ABCs, you won't have a patient. Also, just overall show good judgment. Get a good idea of the sick or not sick, high priority, low priority. That's really the key of the treatment part of this chapter. So our general principles of what we want to do for these patients is stabilize their cervical spine, suction the airway, insert an OPA or NPA if needed, restore a patent airway, ventilate with a BVM if needed, administer high concentration oxygen, control the bleeding, and immobilize the patient if needed. This shouldn't look unusual to you. This is your primary assessment. If you go to your assessment sheets, this is almost in order what the sheets have done. So these sheets do guide patient care and they tell you what you need to spend your initial time doing, and your stop and treat zones, and if you can't treat it, you don't move on zones. So most of this chapter is not too big of a surprise. This is why I kind of like this as an introduction to trauma. Let's go on into a little bit of chapter review. Multisystem trauma is a serious condition in which two or more major body systems are injured or affected. Recognizing multisystem trauma, triaging properly, transporting promptly, and choosing the correct destination are vital for the survival of your patient. Remember, your primary assessment should determine whether your patient is seriously injured or potentially seriously injured. Remember to limit seeing treatment to life-threatening conditions. Remember, use patient severity to decide whether to transport to a trauma center or a local hospital. A patient was involved in a car crash with significant intrusion into the area where the patient was sitting. The patient is alert and complains of pain in the ribs. The pulse is 96 and regular, respirations are 30 and adequate, blood pressure 100/62, pupils are equal and reactive, skin is cool and dry. Your partner says the patient is stable and could easily be transported to the community hospital nearby. You think the patient should be transported to the trauma center. How would you justify your decision to your partner? So, since the patient is complaining of pain in the rib area, there is a potential for considerable blunt force injury trauma due to the crash. You should be alert for unseen internal injuries and the possibility that the patient may need critical care, which is better supplied by your trauma center versus your local hospital. So this one's kind of hard to envision without actually seeing the patient live, but it was on one of the first slides of this chapter. It's always better to err on the side of caution than not. It's better to bring them to a higher center than to undertreat and not bring them to a center and have them be transferred out and have a delay in care. That brings us to the end of this chapter. Like I said, it's a nice and quick one, and just kind of some general rules of how major trauma calls work. So hopefully this kind of reinforced a lot of what we've been talking about with trauma already. And if this is your first exposure to trauma, then welcome to the trauma treatments. And it is a fun section to go over. There is a lot of content in trauma, and it's fun to fix patients. So until next time.